For this lecture, we will cover Chapter 8, Antibody Detection and Identification. Now, as you recall, doing a blood type is going to be the first step in doing testing within the blood bank to determine a patient's blood type. And then beyond that, the additional step that we do for testing is going to include an antibody screen. And what that is going to do is actually detect whether or not there are any antibodies within that patient that could potentially cause problems. So when we do an antibody screen, this is going to be part of the workup for patients who are going to need a transfusion, for any pregnant female who is of which we are looking to see if any of those antibodies have developed that could potentially harm the infant. And we would also do an antibody screen for patients who have had any sort of transfusion reaction, just to see if any of those antibodies are present that have caused that transfusion reaction to take place. And as well, we also look for the presence of any sort of antibody within our blood donations, so our blood and plasma products. Now, what an antibody screen actually does is it will use the patient's plasma or serum, and then we will test that against our reagent red blood cells. So again, our patient is our unknown. When we get our patient tube, it is our unknown. We do not know what is taking place within that patient as far as their antigens and antibodies and anything within the patient's body for that aspect. But when we're testing within blood bank and we're taking that plasma or that serum, again, that's where your antibodies are present at. We're testing it against known reagent red cells that have antibodies already on those red cells to see if there's any sort of agglutination or reaction that takes place. And what we're looking for is those unexpected antibodies. So usually we have those anti-A and anti-B present within our patients, but we're looking to see if there's any additional antibodies beyond those normal blood type antibody type reactions. So our unexpected antibodies are a result of some sort of red blood cell stimulation, and this can happen through things like transfusion or exposure through red cells that could potentially cross the placenta, as in pregnancy. So that infant or that fetus has its own red blood cells, and so if those happen to cross back across the placenta to mom, then that can cause mom to actually stimulate and make those antibodies against those red cell antigens present on that newborn, because remember, that baby is also getting that genetic makeup from the father as well. So mom could be actually responding to those antigens that the baby inherited from the father. Now, those unexpected antibodies, they could be clinically significant or they could be not clinically significant. So we're going to talk a little bit about those in a little bit more detail and detecting those on these panels. But also in the Chapter 7 lecture, it goes into a little bit more detail about each of the different antigens and the antibodies that can be made against those and whether or not they're IgG or IgM. Of course, with our IgM, that's considered more of a cold type reactant antibody, so it's typically not an issue in blood bank, but occasionally you can see some scenarios where it does cause some issues. But most of the antibodies that we're looking at to actually stimulate any sort of transfusion reaction type of response, it's going to be those clinically significant IgG ones. So clinically significant antibodies, as stated, are usually IgG. They react best at 37 degrees and within the AHG phase of testing. And this is also considered the indirect antiglobulin test. And then they also are associated with hemolytic transfusion reactions as well as hemolytic disease of the fetal newborn. Now, just to kind of give you a few little tips, the ortho panel itself actually has listed at the bottom the mode of reactivity. And so you can see based off of this which ones do react at the various phases. So you see that your RH antibodies will react at 37 degrees Celsius as well as AHG. And then you have this whole slew of antibodies that react at antiglobulin phase. So these are your KIL, your Duffy, KID, and X-linked. And then you have some that are cold as well as variable. So your cold ones are listed here. They're your M, N, and your P. And then your variable just means that they could react at room temperature. They could react at enhancement of like 4 degrees Celsius. They could react at your AHG phase. It's just variable based on the particular antigen makeup as far as how it's going to react for that particular individual, and how that antibody responds, as well as the various factors within the patient as far as, you know, if it's been stimulated, if they have a stronger response, things like that. So there are a lot of variabilities that can play into your ones that have this variable type of reactivity. Now, as far as your phases that you're going to do pretty much in blood bank, it's pretty simple. You will have either immediate spin phase or an incubation phase. Your incubation phase, now that could be incubating at a variety of temperatures, and of course most things are going to be incubated at 37 degrees Celsius, but you do have some tests like antigen typing and things like that, that maybe it's a room temperature incubation, or maybe it's a 4 degrees Celsius, or that's pretty much the main ones that you're going to have, but there could be some variability as far as the incubation, and it could be some variability as far as time. So depending on if you add enhancements, it could be something like a 15-minute incubation, a 10-minute incubation, 5 minutes. Just always refer to your procedure for whatever you're doing as far as that testing goes with that incubation temperature and time. And then of course you also have the AHG phase, or your anti-IgG, where you're using that anti-IgG reagent to look for those reactions. But of course in between here you have a very important step. So if you do immediate spin, incubation, anytime before you go into an AHG type of test, you're always going to do a wash. So that's very important to make sure that you're always doing that wash phase before you add any of that anti-IgG reagent. And then of course this is not really a phase, it's just to kind of confirm your AHG reactivity. You have those check cells or Coombs control cells that you will also do, and that's those phases of testing to confirm that AHG phase. Okay, so how do we determine if a patient does have an antibody? Well, of course, we've got to do some sort of screening to see if there are any antibodies present. So to do that, we will do an antibody screen. So typically when a patient comes in and they need a workup for anything like a transfusion reaction, prenatal testing for our mom to determine what her blood type is and if she has any antibodies, or if you're doing any kind of testing for like possibility of a transfusion or transfusion, then you're going to do that antibody screen. So what are those screening cells that we use to do that antibody screen? Well, they are single or pooled donors of group O cells. Single donor vials do have a increased sensitivity because you do have only that one donor in there. But all of these cells are group O, and the reason why they are group O is because if a patient is another blood type, or if a patient is, let's just say that they are an O, and that means that they produce anti-A and anti-B. If we were to use a donor cell that was an A donor, then you know that that O donor, or that O patient's anti-A, is automatically going to attach to those reagent cells or those A antigens on those cells. So therefore the cells themselves have to be group O so that they are lacking those A and B antigens, so that the patient's blood type antibodies don't react with those cells. So your screening cells will come in a set of either 2 or 3 vials, just depending on the manufacturers and what the laboratory's preference is. You can see some examples here of a 2 vial set as well as a 3 vial set. So you can see you've got your screening cells 1 and 2, and then you've got your screening cells 1, 2, and 3. Now, I would make a note that these particular reagents, this is not a very good image. These reagents look like they've probably just been sitting in their rack or whatever. So what has happened is these cells have settled down to the bottom of the reagent vials. But something that I want you to make a note of is that all of these reagents do look hemolyzed. So that's supernate for these reagents is hemolyzed. If I were to receive this in my lab from, let's just say, a new shipment, I would reject this because that visual inspection does not pass of these reagent cells, because there is some lysis of those cells going on, which means that hemoglobin is leaching out into that supernate, causing that hemolyzed look to those cells. So if you were testing a patient and you use these cells, when you spin it down, obviously that supernate is going to look hemolyzed, which means that could be a false positive reaction. So remember that hemolysis is considered a reaction. So if we have this in our tube when we test it against our patient, it's really the screening cells that have that hemolysis, and not just because of an actual reaction, or rather, we don't really know if there was a hemolytic type of reaction due to that particular antibody. So we would not want to use these. Okay, so each vial, or those donors that are within those vials, have been phenotyped for their antigen profile, their antigen makeup. Now, there are 18 antigens that are actually required to be present on at least one of those vials. So those antigens that have to be present are going to be those ones that you see on those panels. Now, there usually are a couple of other cells that are in addition to these on those panels, but at minimum, those cells have to have at least this makeup in order to make those screening cells for that particular screening cell set. And that's why sometimes you may have to go to a 3-cell to ensure that you have enough reactivity, depending on your donor, your center, where you're at, your blood bank, as far as what their preference is, what they're going to use. The purpose of the 3 over the 2 may possibly be for just to have more variability for doing things like testing, using these cells for testing as your QC for your antigen type, and it just gives you more variability of positive and negative selections. Okay, so more on these screening cells. They too come with that sheet of paper, that anagram. And that anagram, again, it can be 2 or 3 cells, so depending on the vials that you use. And what they're going to do is actually list the antigens that are present for each of those vials. A reaction to one or more cells indicates the presence of an atypical antibody. So in other words, if you were to do your testing, your immediate spin, your incubation, and for this particular test, it's going to be 37 degrees, and your AHG phase, and then of course your check cells. So if you go through this testing and you have reactions that happen in one but not the other, then you would consider this to be positive. So it doesn't really matter where at in this whole process that this reaction happens, as long as you have some sort of reaction. So you could have one reaction here or one reaction here. Doesn't really matter. If there's a positive reaction at any point, now this does not include your check cells. Remember, this is a validation, so we're not going to include our check cells. If there's a reaction anywhere in your testing, in any phase for either cell, that is considered a positive reaction, which means there is some sort of antibody present. Now, this PowerPoint says atypical, but we know that that means it's an allo antibody. It's just not supposed to be there. Now, to perform the antibody screen itself, then you would label your tubes. Of course, if you're doing gel testing, of course you would do those gel wells. But you would label it with whatever your screening cell is. So if it's a 1 or a 2, or if you have a 3-cell, then that is what your tube is labeled with. Okay, and now to that tube, you're going to put your patient's plasma, so usually it's 2 drops of patient plasma, and then you're going to also add to that the actual drop of the screening cells. So to tube 1, you would add a drop of the reagent screening cells that are for vial 1, and then vial 2 and vial 3. So each of those gets their particular reagent that is labeled for that tube. And then from that, you would take that through those 3 phases of testing that we referred to up here. So you would do your immediate spin. If your particular lab uses anything like your LIS reagent, then that LIS reagent will actually be added. Let's get another color here. Will be added before you put it into incubate. So your immediate spin would happen first, and then after you record and document that particular reaction, then you would add your LIS reagent. So it's usually going to be the same number of drops as the plasma that you added. And then from there it would incubate. So you would incubate that 37 degrees Celsius, because again, we're trying to allow any of these antibodies that react best at the 37 degrees, or that react best at AHG. We're giving those time to enhance and react, and we're allowing that reactivity to take place. And then after that, then you would go through your next step, which again, remember what I told you happens here before you go to that 3rd step. You're going to have a wash phase. So you would use a cell washer, or you would manually wash it. And then after you've done your wash, you get that dry cell button. And hopefully what will happen is anything that's unbound is going to be washed away. You'll have clean cells, and you'll actually have some sort of reactivity if that antibody is present, where you have that bridging taking place with those red cells and getting that positive reaction taking place in that tube. When you add that AHG, that starts bridging all of those connections together because of that anti-IgG type of antibody. So we're looking to detect those. Now just keep in mind that to all of your negative reactions during that AHG phase, if they're negative, then they're going to get those check cells, or those Coombs control cells. Autocontrol. So what an autocontrol does is it actually tests a patient's serum against his or her own red blood cells. Now, typically when you're doing a blood type, we don't always do an autocontrol, depending on the system that you're using. If you're using the tube method, some labs may have you do an autocontrol. Most will not. They will only do an autocontrol if they need to investigate an AB positive patient, just to kind of confirm that they're not agglutinating themselves, or any other kind of investigation with ABO discrepancies and things like that. But your autocontrol will be ran if you're doing, or you're working up a positive antibody or a positive antibody screen. You can do an autocontrol with your antibody screen. Most places don't, because typically most people will be negative, and you're already going to have to do a panel if that antibody screen is positive. And most of your panels do have a spot where you actually will put your patient cells and patient's plasma to actually run that autocontrol. If a laboratory technician uses an autocontrol with a screen and it is positive, then you need to do a DAT. So why would you do a DAT? Well, the DAT is basically your patient's red cells tested against AHG, or anti-human globulin, and your patient red cells are going to be washed, removing anything unbound, adding that AHG, and then you're looking to see if those cells have been coated in vivo within the patient by any sort of antibody that's causing those cells to self-agglutinate. Now, most places when they do a DAT, they will do a poly-DAT, which is going to look for any sort of IgG coating as well as C3. But just keep in mind that when you're doing the panel testing, you're most places are just using anti-IgG. They're not using polyreagents. So really just testing against the IgG is really only the only necessary part. The auto-control and DAT will help determine if the antibodies are directed against the patient's cells or transfused cells. So keep in mind that when you're running or doing an antibody screen and you have an antibody, your next question is it an allo antibody or is it an auto antibody? So with an auto antibody, we know this is against self, whereas an allo antibody is against something else that is non-self. So an allo antibody are going to be all of these other antibodies that we talked about. That's like a D, E, KIL, etc. So that is why we do an auto control when you're running this panel. Again, you're going to run it and take it through all three phases of reactivity. Of course, immediate spin, your incubation, your AHG phase, and of course, check cells if they're necessary. Again, those check cells are only there to validate the test. They're not considered a positive reaction. So potentiators are used in blood bank in order to help with enhancing those antigen and antibody reactions. Saline, it can be used, but it's really only best if you're going to incubate it for a really long extended period of time, 30 minutes, hour. Your low ionic strength solution, this is your most common reagent that most blood banks will use, your LIS reagent. And depending on the manufacturer, that incubation time is usually 10 to 15 minutes. I think some of them could go up to 20, but typically a 10 or a 15-minute incubation, just depending on what your procedure says for that particular reagent and what your blood bank does with it. You can also use albumin. So here's a picture here of your albumin. Depending on what you're testing and things will depend on which potentiator you may use. Of course, you can use PEG, and then there are some other proteolytic enzymes that will actually destroy the various antigens and help with your antibody workup for those allo antibodies, especially when you have multiple. Now, these were covered in your Chapter 3 lecture, so you can go back and look at that, but your textbook does have a nice little chart that kind of further elaborates on each of these potentiators, and then it also breaks down your gel as well as your solid phase technologies. And with your gel and your solid phase, they have been shown to increase or enhance some of those warm auto antibodies, and so that is kind of one of those things that has become a little bit troublesome when you have those warm auto antibodies that are present, because it's going to interfere with that particular test methodology. However, there are ways to kind of clean that up a little bit. But again, most of your labs will use your LIS reagent, so it does enhance your cold autoantibodies. You have some weak anti-K antibodies that can be mixed with this, but for the most part, you will be able to kind of detect most of your more common antibodies that are going to cause problems. Again, you can review these, look at this chart, and kind of go over these again. These enzymes, remember that what they can actually do is when you actually treat those panel cells and stuff, it can eliminate the presence of some of those antigens and help with those workup of multiple antibodies when you have those present. Now, anytime you bring a patient, when you have a patient sample in blood bank and you are working them up and you're setting up your blood type and your antibody screen or your panel, then you will actually, while that's incubating and you're going through those steps, before you actually enter your patient results, or when you're entering patient results, or investigating anything, you're actually going to always check your patient history. Now, why is it important to check patient history? Well, that's going to give you a lot of valuable information to help you with determining what you're going to do with that patient. Because if your patient has previously been transfused within the past 3 months, then you know that you're going to have a mixed red blood cell population. So as you recall from hematology, a red blood cell will survive how many days? Approximately 120 days. So 120 days is 3 months. So we can pretty much just assume if a patient's been transfused within the past 3 months, then there's probably some red cells that are donor red cells still within that patient. Not likely, because what's the likelihood that they got a 1-day old? A majority of those cells were 1 day old. Not likely, because as you know, you're producing new cells every day. So, of course, as they get further out from that transfusion, there's less likely to be donor cells there, but we still need to err on the side of caution and just assume that there could be donor cells there. And so when there are donor cells present, we know that they have the potential to make any of those antibodies that we just talked about anytime while those red cells are circulating. So we always have to keep that in mind. So we also need to get the history, because patients could come from another hospital. So if you're actually working up a patient and you're getting some weird reactions and things like that, and you're trying to investigate it, if you don't have any history on file at your facility, sometimes you might have to query the nurse to ask the patient if possibly the patient has had transfusions or anything at another facility that could potentially have caused that patient to have some discrepant results. Sometimes you can call those other facilities and they'll have a lot of information that they can share with you as far as the antigen and antibody history, or any problems that they had working up that patient with that particular, any of those particular problems that they may have. Let's just say they have a history of a Duffy that's not showing up right now, then that would be good information to know, because as we know, that Duffy can cause, has the potential to cause transfusion reaction. Occasionally there are some diseases that are associated with various antibodies and things that we can see. So just being aware of those. For example, if a patient has multiple myeloma, then you could be seeing some of that reactivity being present within your panel. And showing some agglutination due to those proteins. Some antibodies will happen at a higher frequency in some races, so being aware of the race will help you when you're trying to figure out some of those more complicated antibodies. And then it can give you information like the diagnosis, the age, race of the patient. So all of those things can factor in. Age more specifically, so we know if let's just say that you've got something down to cross-match an infant that is just 2 months old. Well, we know that at 2 months, the infant still has mom's antibodies present. So this is one of those scenarios where we're going to have to check on to see what mom's got going on. Does mom have any antibodies that we potentially have to honor, because baby could have mom's antibodies circulating, causing a problem. Also, that elderly population, remember, they have those weaker expressions of those antibodies. So sometimes if you are testing a patient that's elderly, then you're getting weak reactions, that could kind of help you understanding why those reactions are weak. Okay, so you've done your antibody screen and it's positive. What next? Well, we have to figure out what is that antibody. If our antibody screen's negative, our history's good, there's no history of antibodies anywhere, or any other complications, then we know that we're good to go. We don't need to do an antibody workup, but some cases we might have to do an antibody identification. So initially what we'll do is run a panel. And so your panels can actually consist of 10 to 20 cells, just depending on the manufacturer of that particular panel and what your particular lab chooses to use. So basically what it is it looks like that antibody screen, except you have an extended version. You have more cells, because this is going to help you do the process of ruling out and eliminating what potential antibodies are present. Just like your screening cells, these cells are all group O individuals, and then each panel cell has been antigen typed to list the phenotype of each of those, and then that is listed on the anagram that you will use to record and interpret your results. All right, so those panel cells, how do we actually interpret them? Well, we have to look at a few things. We've always got to look at that autocontrol. Is that autocontrol positive? Because if it is positive, then that means we need to figure out why it is positive. So we need to check that DAT to make sure it is, see if it's positive or negative, to help with that investigation. Now, if it's an alloantibody, it could be due to recent transfusion or pregnancy, something like that. Negative autocontrol indicates that there is an alloantibody present. And so when you've got autocontrol positive, it doesn't necessarily exclude that there is no alloantibody. It just means you have multiple things going on. Positive autocontrol plus a negative DAT indicates that the test is false positive. So if your autocontrol is positive, but you know that your cells have not been coated with anything in vivo, then more than likely it's false positive due to something else, so you would need to figure out what that is. So this could be one of those scenarios where maybe you've got some of those abnormal proteins, or you've got something that's causing the rouleau. So that is what's actually causing that agglutination. Sometimes you can have some scenarios with your gel wells and those gel cards, where certain times of the year or something that's going on, it's like there's a lot more static activity in the air, and because of that you actually will have those cells kind of draw to the sides of those plastic wells. And so what they do is they just kind of cling out and they stick there for a little while, and then after you've spun your gel well down and most of your cells go to the bottom, when you take it out of that centrifuge and it sets a little bit and that kind of atmospheric static changes take place, then you'll see where those cells will just kind of come down and they'll settle across the very top of that gel matrix, and then you'll have a little layer at the top and a little layer at the bottom. So sometimes you can have some false reactivities that way. So your phases, when you're interpreting these, you want to pay attention to what phase of reactivity you're actually seeing those positive reactions. If you're seeing them at immediate spin, then you know you're dealing with something that reacts at room temperature. And of course, this is your IgM antibodies. So this means you're looking for things like Lewis, your M and your N, your I and your P1 antibodies. Your IgG antibodies, of course, they're going to react at 37 degrees and or your AHG phase. And when we're looking at the phases and we're noticing that we have different reactivity, then that's going to help us kind of narrow down, are we dealing with an IgG antibody or an IgM antibody? So here we have an example of a patient that we've worked up, and we've set up in this particular panel here, you've got 10 panel cells plus the autocontrol. So that means we had 11 tubes, so each of those tubes were labeled with whatever was in it. So tube 1, 2, 3, etc. And then to those tubes, of course, we added our patient's plasma, as well as that particular red cell vial, that one drop of that vial 1, added to that tube, and then we took that tube as well as all of those additional tubes. So we had 2 and 3 and 4, so we had a tube for each of these. We took them through all 3 phases of testing, and this was our reactions that we got with this testing. So you can see here that again, remember that we're looking at this particular panel here. They use lists as their enhancement, but we're looking at these three phases. Again, your check cells is just a check. Just because it checked or it worked, it was positive. Of course, some labs will grade these, usually 1+ to 3+ type of reactions here. If those check cells works, that just validates that your AHG worked, that phase of testing is valid. So we don't consider this a positive reaction, only the reactivity that happens within the three phases. So when you look down here, you're looking to see if you have reactivity anywhere. Well, of course, we do here, here, and here. Those other ones are negative. But if we look at our autocontrol is negative through all three phases of reaction. So we're able to kind of answer our first question. Is it an allo or is it an auto? So based on this, the fact that we have a negative autocontrol, that means that we can exclude it being an auto type of antibody and say, yes, we're definitely dealing with an allo type of antibody. So what do we do next? Well, we've got to figure out exactly what it is by a rule-out process. So we use our interpretation guidelines. We look at things like the strength. The strength of reactivity can vary based off of the fact that we can have multiple antibodies in there, as well as remember that we have some stuff that shows dosage based off of whether or not it's homozygous or heterozygous. Ruling out the antibodies. So when we have those panel cells, then what we're going to be looking at first, okay, we recognize which ones reacted. Then what we're going to do is say, okay, which ones didn't react? Because if it did not react with that particular antigen that is present on those red cells, let's just say it had a D antigen present on that particular red cell. If it did not react to it, then we know that it did not react with that D antigen. So again, we're looking to see not only which ones it reacted with, but which ones it did not react with, because those ones that it did not react with are the ones that we're going to use to do our rule out. So first we will begin with the panel cell that is negative for all phases, and we're going to cross out those antigens that are present. We're going to look for panel cells that are heterozygous, because those are not going to be crossed out because that particular antibody could be very weak, and that means it's not reacting with those heterozygous cells, because remember, when you've got those heterozygous cells, you don't have as many of those antigens for that particular antigen phenotype or whatever present on those particular cells, so you can have a weaker reactivity due to a weaker expression of those antibodies. So maybe you don't have as many of those antibodies present. Could be a newly forming antibody, one that's not been stimulated in a while, so it's weaker. So there are a variety of things that can actually cause those weaker reactions. Now, once we go through our rule out process, then we're going to start matching those patterns of reaction in those anagram columns to try to figure out what we actually have going on. And if we suspect that we've got multiple antibodies, we've got to look at those various patterns that they are demonstrating in that reactivity. And then we also use the rule of three. So what the rule of three does is it ensures that we have valid results, because we're looking for 3 antigen positive cells to react. Now, this could be on our panel as well as our screen. So keep that in mind, that we are looking at multiple things to confirm that 3 antigen positive cell reactivity, and then 3 negative antigen cell reactivity. Again, we can use those panels as well as those screening cells. If this doesn't happen, then that means you might have to run additional panel cells. And when you run additional panel cells, we refer to this as selected cells. So you actually select which cells out of additional panels you want to run. Now, keep in mind that if you run panel A and you ran cells 1 through 11 as well as your autocontrol, you cannot pick those selected cells from panel A. You've got to get a new panel. So this means you might have to go to panel B and pick one of those cells out of panel B to run. Okay, so let's go back to our example that we had where we had those that I just showed you earlier. So we recognized which ones were considered positive. So that's cells 1, 3, and cell 7 are positive. We've looked at our autocontrol. We determined that our autocontrol is negative, so we know that we're dealing with an alloantibody. So that just means that we're dealing with one of these RH, MNNS, P, Lewis, Lutheran, Kale, Duffy, Kidd. So when we look at these, we're looking at the negative reactivity to do our rule-out process. So with our rule-out process, when we know that there was no reaction at any phase of the test, an immediate spin, 37 degree, or AHG, we're going to look for our first negative reactivity all the way through. So that's going to be cell number 2, the one that we're going to look at first. And we're going to go across and do a rule-out process. Keeping in mind our heterozygous versus homozygous, we only want to do rule-outs on homozygous cells. And when we're doing our rule-outs and we're going across, I want you to keep in mind that when you see these pluses, that just means that that particular antigen is present on that particular donor cell there. So for example, when we're looking at our cell number 2 here, we know that this particular donor has the D antigen. That means that they are what blood type? That means they're O positive, because remember, these are all O donors. And then we also have our RH phenotype listed here. So R1, we know that that's got to do with all of this RH phenotype. We talked about that with RH nomenclature. So, and then we know that we've also got some RH negative donors here. But looking at cell number 2, this particular donor has the D antigen. So we know that if we mix this donor with our patient who has an antibody and it did not react, well, we know that antibody is not anti-D, because if it was anti-D, it would have agglutinated. So let's do the rule-out process. Now this is my particular way that I do a rule-out. Everyone does them a little bit different as far as how they indicate they've done the rule-out. But the way I like to do it is I like to actually mark on the panel cell itself where I did my rule out. So for example, I'm ruling out D on cell number 2, and then I come across the top and I also rule it out. All right, let's move over to our next. So our next is a big C, but we also know that big C is inherited with little c. So we're looking to see, is big C heterozygous or homozygous? Well, it is homozygous big C, which means that we can go ahead and safely rule that out. Next, we look at E. So big E and little e are inherited together. It is no E present, no big E present. Now we're looking at little c, it's not present. Little e is homozygous little e. So we know that if the patient had an anti-little e, they should have agglutinated here, and they did not. We're ruling out. All right, let's look for our next antigen that's present, which is CW. We can rule that out. M. All right, so M is inherited with N, so we check those two together. Big S, little s, homozygous little s, so we can rule out. P1. Lewis B. Lutheran B. Little k, Duffy B, JKA and JKB. So this is heterozygous. So we know that we could potentially have some weak reactivity going on, so we're not going to rule those out just yet. All right, now we're going to our next negative reactivity, which is going to be number 4. And we've already ruled out those first couple, so we can kind of skip them. Next, we're looking at E, not present. C, little c antigen is present, but it is a heterozygous cell, so we cannot rule out based on that. F. All right, going on across. S, it is hetero, big S, little s. Lewis, keep going across and till we can get something else. So we've got Duffy A. It's homozygous, we can rule that out. And JKAMV, hetero. Alright, so our next cell, we're moving on. Okay, number 5. We've got big E, homozygous, big E, so we can rule out here. Moving on, C, homozygous little c. Next, we're going all across to N, so M and N, hetero, cannot use it. S, big S is hetero, cannot use it. Lewis, let's keep going, Lutheran, kill. And JKA, homozygous JKA, so we can now rule out JKA. Our next cell. Alright, so let's see, we're kind of running out of cells we can use, so we're still can't rule out N, still can't rule out big S, Lewis A, so we can rule out Lewis A here, this homozygous Lewis A, Lutheran A, kill, still hetero, JKB, hetero. Alright, next cell, I'm just going to kind of go down and look at N and see if I can rule it out anywhere because I've kind of narrowed it down. So it looks like I can rule out N on this last one, not here on number 9 because it is a hetero. And big S I can rule out here. Alright, Lutheran A, there are no antigens present on any of these donors for Lutheran A. It's highly unlikely that it is a Lutheran A. Kill, nothing there. And then JKB, I can actually rule out on number 8. So if we go back and look, and we've kind of gone through and ruled out about everything we can, the only things that we are left with is a KIL and a Lutheran A. Now again, I kind of mentioned there's no antigens present, so we know if none of these donors had the Lutheran A antigen, it's not likely that the Lutheran A is causing any of this reactivity. I'm going to rule this out based on probability. This is just my way that I do it. Labs do this different, so someone else could teach you differently. I just kind of rule out with a line down. Typically don't run all the way through the panel. I just basically just kind of did that for a demonstration here. Oops, erased something I shouldn't have. I usually just kind of keep it simple and I just do this. That way I know that I ruled it out on probability. Which leaves us with just KIL. So let's look at the other things. Do we think we're dealing with an IgM type of antibody? Did we have reactions at immediate spin? No. Do I think I'm dealing with one of these 37-degree or AHG type of reactivity of an antibody? Yes, we do know that KIL is an AHG. That matches that. Next, let's look at our pattern. So we see that we've got a 2+ reaction, a 2+ reaction, and a 3+ reaction. So we have some variability in our reactivity. So we see that we have a stronger reaction and a weaker reaction. Now let's see if we can validate why we're seeing that reactivity that way. Well, if we come back and look and see how KIL is expressed on these particular donors, we see that we have a little bit of that dosage going on. So we have some stronger reactivity with that homozygous cell, and we have weaker reactivity with that heterozygous cell. But when we are done with this panel, as far as working it up, when we determine what we're going to enter into our computer system or what we're going to say that this patient has, we're going to say that they have an anti-big K or KIL. And that's pretty much all we do as far as the rule out process on the panel. So here you have your textbook explanation of the panel that we just worked up. Of course, they got the same thing. They could not rule out Lutheran A or Big K. One thing that I want to mention is it does state here the rule of 2, where earlier it says the rule of 3. Some labs will use the rule of 2, some will use the rule of 3. You're really going to have to kind of follow your lab, but what that means is it's just that you need 3 negative cells. So we've got 1, 2, 3, and then you also need 3 positive cells. So we have 3 negative reactivities where the antigen is lacking, and we also have 3 reactivity where the antigen is present. And let's see, anything else that I need to, okay, showing dosage. It does mention of its showing dosage where we have that difference in reactivity of that 3 plus versus that 2 plus. Okay, so additional step in those interpretation guidelines. Now, once you actually do that rule out, you determine what that antibody is, you are not done. You have additional testing that has to be performed. So just like your blood type, where you do a forward and reverse, so that reverse confirms that forward type, phenotyping will also confirm what you're finding within your antibody workup. So for example, this last patient that we worked up, we determined that they had an anti-Big K. That means that their red cells, if they've got the antibody, then their red cells should lack that K antigen. If that K antigen's actually present, so if we have those K antigens present, then we know that if that antibody in that patient is actually a K, then it's going to agglutinate and it's going to cause problems. So we know that if they have the antibody, they have to lack the antigen. So they cannot have that K antigen on their red cells. So we would phenotype that. So to phenotype it, you're actually just using a vial of reagent that is, you guessed it, nothing but anti-K. That's all you're seeing in that reagent is just straight anti-K. So you would actually test it against your patient red cells, and you would also do QC. So let's imitate that. So if we were doing QC, that means we need a cell that has the antigen and a cell that lacks the antigen. So when we do our testing, this is where we would use those reagent red cells, that screening cell, and then we would actually test our patient. So where I mentioned earlier, if you have a 2-cell or a 3-cell, you're going to need something that's going to be positive for that particular antigen and something that's negative. So if we're testing our KL reagent, we're looking at that panel cell to determine, okay, which one has KL present and which one does not have KL. So we see that tube 1 has KL. So we would expect if we mix it with anti-K, we're going to get a positive reaction. And tube 2 does not have that KL antigen. That means if we mix tube 2 with anti-K, we should expect a negative reaction. And then again, if our patient has anti-K, that means they lack the antigen. We would expect our patient to also test negative. So you would use your phenotype in sera or your anti-K and test it against your positive control, negative control in your patient, and your patient should be negative. Now, if we had done worked up this panel, we determined anti-K, but our patient tube ended up testing positive instead, then we've got a problem. This is a no-go. What that means is possibly maybe our patient's been recently transfused or something else is going on that you need to do some further investigation to figure out what's going on here, what kind of issue do we have, because that doesn't jive, something doesn't make sense. So when you've got multiple antibodies, this just means you have more than one. So perhaps your patient has something like they have an anti-D, but then they've also got an anti-KL, but then maybe they've also got an anti-Duffy A. So when you have those multiple antibodies that are present, it's going to cause problems because you're running out of cells to actually work up those antibodies and get those negative reactions to do your rule out. So it starts getting a little bit more complicated, and you got a bigger puzzle that you're trying to work. So when you have multiple antibodies, this can be indicated when you have varying reactivity that's going on. So maybe you're seeing different reactivity in different phases of testing. Maybe you're seeing different strengths of reactivity. Regardless of what it is, if you've got some varying reactions that are being observed, then that kind of indicates that you might potentially be dealing with multiple antibodies. So this means you just might need to employ different techniques to kind of help with identifying those antibodies. So this will include things like selected cells, the proteolytic enzymes, various chemicals that can denature those kill antigens and things that are actually on that panel. So you would actually treat those panel cells to remove some of those antigens and things like that, or to enhance some of your reactivity, and test those cells again to see if that will aid in your process of elimination. Now, if you use those proteolytic enzymes, they're used to eliminate or enhance antibody reactivity. So, for example, you could use them to actually destroy your Duffy, Mn, and S antigens. So let's just say that maybe you have some reactions that are taking place that you suspect are possibly some sort of cold reactivity, possibly that you've got an anti-M. So you would treat those panel cells and then retest them. And what that treatment's going to do is actually remove those M antigens, so that where you would have reactivity against that M antibody, it's not going to take place. So it allows any other antigens that are present to react with the particular antibody that you're looking for. It can also enhance your Rh, KIT, and Lewis antigen reactivity. You have one-stage tests, so you have your enzymes, your red blood cells, and your serum that are simultaneously incubated. So you're when you do that, you're just doing that one test. If you have a two-stage test, then what you're actually doing is you are pre-treating your panel cells, and then you are, once you've treated them with that enzyme, you've actually got to wash that off and then retest it. So depending on the particular enzyme that you're doing and what you're actually trying to accomplish will depend on which of those you will do. So what we have here is an example of a panel that has been treated with Ficin. So what Ficin will actually do is remove those Duffy A antigens. So for this particular panel, what happened is first they ran it like normal. So they ran it with that LIS enhancement. You don't see your immediate spin reactions here. We're going to assume that they were negative. I'm thinking the book just saved space with this panel here. But if we were to do our rule out based off of this first scenario, so I'm going to do this in blue, then the particular rule out for the cells that we're going to use is going to be these ones that reacted negative. So it's just cells 1, 2, 8, and 10. Of course, we always want to look at our auto control. Is our auto control negative? Yes, that means we know we're dealing with an allo, not an auto. And we'll go through our rule out process. So I'm going to kind of do this real quick where we go through. I'm looking at hetero versus homo here. E, M, N. Let's rule out S. P, Lewis A, Lutheran B, Kill, can't rule out, Duffy B, JKA. Going to my next panel cell, and I'm just going to kind of run through this real quick. Little s can be ruled out, Lewis and K. And can't do JKB just yet. All right, try not to get confused here. So I'm only doing the LIS reactions. All right, little c, I'm on the right one, 8. F, No N. Kale still can't be ruled out. JKB. And this last one, just going to kind of run through, actually running through kind of backwards here, just to make sure I didn't miss any that can potentially be ruled out. Here we got N, and E is not in there. All right, just kind of looking through these last ones that we got left. So based off of that list rule out, we're still left with E. Lutheran A, it's not likely. Kale can't rule out. So that's what we're left with, as well as the Duffy. So got a couple of options here. We could probably run an additional panel and successfully figure out what we've got going on here, because we're only left with E, your Kale, and let's just kind of bring this up a little bit here. E, Kale, and Duffy A. So that's what we're left with just by doing that Vicin. Now if we look at our reactivity here, we've got some 3+ reactions, 2+ reactions, 1+ reactions. So we know that we've got either some dosage going on, we've got some mixed strength reactivity here, or we've got multiple antibodies. So what they chose to do here, because of that Duffy, and really kind of thinking that that's probably what it is, just based off of the dosage that's kind of demonstrated here, where you've got these 1+ reactions with your heterozygous and 2+ with your homozygous. You know, there's really no need to do any kind of additional testing, because if you use where the textbook said 2 positive reactions, you've actually got those here and here. Oh, excuse me. You got those 2 positive reactions there, and you can see where this E is heterozygous, so it's a little bit weaker there. And then you got the Duffy that's reacting. So I wouldn't do any kind of Vicin treated cells, but let's just say your policy is to do it. So what you would actually do is treat these cells. You would do a little aliquot, or you would do a manufactured kit that already has been Vicin treated. But you would treat those with the Vicin, and of course, you know, you would do that according to the procedure. And then you would rerun it just for this AHG phase of testing. So when you treat it, you're actually removing those antigens that are on those cells. So essentially, you're making all of these now be antigen negative. And I'm sorry, I didn't even pay attention to the fact this one is positive, so you've got some overlap here with this particular cell where you've got positive reactivity for E and for your Duffy. But when you do the Vicin treatment, you essentially remove those antigens, making them all negative. Then what that's going to do is allow nothing but that reactivity with that E antigen demonstrate. So that's where you're seeing this here. So if you were to do your rule out now based off of these reactions, again, you got to remember you've removed those Duffy antigens. So this basically kind of helped you kind of confirm and rule in the fact that you do have a Duffy A antibody present. Now our next step from here, antigen typing with using our reagents of anti-E and anti-Duffy A. And what should our patient be, assuming they've not had any transfusions? They should be antigen negative for both of those. Antibodies to high frequency antigens. So this is when most of your population has that particular antigen. So when you have a situation like this, if they have an antibody to it and you suspect that there's an alloantibody to a high frequency antigen, this is going to be indicated when pretty much all of your panel cells are positive. But your autocontrol is negative, so you know it's not an autoantibody. Basically, if you run a panel and every cell's present positive, then you're going to hit freak out mode, because you're like, okay, is it an antibody to a high frequency antigen? Is it something else? Like, what exactly is going on? You're trying to kind of piece that thing together and figure out what's going on. So some testing that can be done to kind of confirm that you have that antibody present would be to do some of those enzymes to either enhance or destroy those antibodies. And then, of course, you have some reagent that will destroy those kill antigens. Now, the likelihood of you doing this just in a regular, everyday blood bank that's in most of your hospitals that have any kind of, that do surgeries or have an emergency room, have OB patients, things like that, you're not going to do a lot of this enzymatic testing and treatments and things like this. This is usually going to be at your blood centers, like your Red Cross or some of your blood centers within your area, whether it's a blood center that's associated with the hospital or whatnot. Sometimes those blood centers, they're going to do more of this this testing that's a little bit harder to do. It's a little bit more troublesome to do. It's very tedious type of testing. And the fact that you have to stay proficient and you may only do this a couple times a year, it's usually easier and more cost effective to send patients like this to these reference labs for them to be able to work it up, because they have better resources than most of your smaller hospital type blood banks have. So here you do have a chart that lists those high frequency antigens. Again, a lot of these you will never see. Occasionally you might have a patient that will come in that will have one of these. If you work at any of these blood centers like Red Cross or anything like that, then you will become more familiar with these. But with that MLT level, basically what you need to kind of comprehend and understand that these can be present. More than likely, if you experience something like this, it's going to get sent to a reference lab, unless you are at that reference lab, and then you're going to have to learn a little bit more about these. So here's an example of that high frequency antigen. So we talk about that as pretty much every donor, every person has that particular antigen. And so you have reactivity pretty much in every panel cell. So you see reactivity pretty much all the way through. If I were to work this up in my lab and I suspected that this is what it was, I have no anti-little k reagents in my blood bank, so I would have to send this to a reference lab for confirmation anyway, for them to be able to kind of confirm some of this stuff. And potentially, if this patient needs to be transfused, they may even need to look for those donors for you in that rare donor registry. High titer, low avidity antibodies. These are your nightmare. So these antibodies are to high frequency antigens that will react weakly. And so this reaction actually takes place in the AHT phase. And they're not really implicated in any kind of problems as far as any sort of transfusion reaction or causing any problems with the fetus, to cause hemolytic disease of the fetus or the newborn. But they're very they cause a lot of problems, because you get this weird reactivity, inconsistent reactions that that you can't really reproduce. They're not clinically significant. Occasionally they're going to be found with other antibodies, which is going to cause a problem, because you're going to get all of this variable reaction going on. So with these antibodies, they're not going to be enhanced really with anything. Your auto control isn't reacting, so it's like just a mystery. You're trying to figure out what's going on. And then you're going to get weak reactions within your antiglobulin phase, that sometimes it can just be microscopic. You're not really seeing it. You may pick this up on gel, because gel is way more sensitive, but most of the time you're going to see these weird variable reactions, and you're really not going to know what to do. So some of the things that they can do would be to do titrations, just to kind of figure out exactly what's going on. But again, this is another one of those things that when you get it, more than likely your lab is not going to be able to do everything that's needed to work that up. So this is something that would get sent to a reference lab of some sort, or a blood center, to really do that workup to verify that it is the high titer low avidity antibody, HTLAs. Antibodies to low frequency antigens. Now these are fun as well because you could actually run your screen, it's negative, and then you go do your cross match and then you got a positive reaction and you can't figure out what happened. So you're repeating everything, and then come to find out you have a low frequency antigen. So anytime you have a scenario where your antibody screen's negative but then your cross match reacts, you want to do a little bit of investigation. Anytime that cross match reacts, something's going on, so you need to stop and take a pause, because if it reacts in the tube, what do you think is going to happen in that patient's body? So when you take that pause and you start investigating, then you may be inclined to do an antibody panel, and then when you do that panel, you'll have that one cell that reacts with something like a CW or a Lutheran A or something like that. And so that's your indicator, is when essentially you look negative, but then you come back and you do your cross match and then you have a positive reaction. So a lot of places have switched over to doing those electronic cross matches now, but you know, I'm still a little old school. I still like to put my eyes on it, and I still like to see what it looks like in the tube before I give it to the patient. So this is where actually doing a cross match, whether you do it in tube or automated some other method, doing that cross match is just going to kind of give you that self-assurance that you are providing the safest possible product. Now, if you're working up antibodies and you've got some weak reactivity and you're trying to figure out what exactly is going on, you know, whether that patient's just got some weak or missing reactions or anything like that, some dosage going on, there are some things that you can kind of do to kind of help that, because you never want to completely ignore a potential antibody, because again, we have just learned about a lot of these antibodies can cause some very severe hemolytic type reactions and destroy red cells, and so we want to avoid that because that causes other complications within that patient. So some of the things that we can do would be like increasing the serum to cell ratio within the limits of what your reagent will allow. So maybe you would, if you started off with 2 drops of plasma, maybe you would do 3 or 4. And what that's going to do is provide a little bit more antibodies to kind of help bridge those reactions if there's less antibodies present due to some weaker expressions and things like that. You could repeat with different enhancements. So let's just say you tried LIS, maybe next time you would try PEG. When you're looking at that panel, looking to see if there's any kind of expressions of dosage that could be happening. You could get different cells from a newer panel, or test a newer panel, or test additional cells, doing some of those select cells, things like that. You could incubate a little bit longer. So let's just say your particular enhancement says that you could incubate 10 to 20 minutes, but maybe your lab has decided to incubate at 10 minutes. So you could let it go a little bit longer, maybe let it go 20 minutes because that's what your reagent says you can go to, and then hopefully enhance those reactions. And additionally, you could do things like phenotyping if the patient hasn't been transfused in the past 3 months, because again, we don't want to test donor cells, we want to test just patient. And with that phenotyping, that could help us rule in or rule out antibodies. So if you're trying to narrow it down between a C and a big C and a big E, and you phenotype and the patient has the big E antigen, then we know that they can't have the E antibody. So that kind of helps further eliminate what the possibilities are, and allows you to kind of more safely determine what to transfuse that patient. Cold allo antibodies are those IgM antibodies that react at immediate spin, as well as occasionally you can have some that will cross over into some 37-degree reactivity and even show up in your AHG phase. Now, if they do show up in that 37-degree AHG phase, you need to honor it. You need to make sure that you give units that are negative for that. They're typically not considered clinically significant, but if you're seeing it in that AHG phase, to be on the safe side, you want to go ahead and transfuse units that are negative. So those cold alloantibodies will include your anti-P1, your anti-M, and your anti-N, and they can have variable reactions. So to enhance those reactions, you could lower that incubation temperature. I have done this before where I'm suspecting a cold, but I'm not quite sure. So what I'll do is just actually rerun that panel, but instead of incubating it in the 37-degree incubator, I'll let it set at room temperature, or I've even placed those tubes or those gel cards in the refrigerator and let it incubate for that 10 or 15-minute periods in that cold environment, which will enhance those cold reactivity. So to avoid reactions, neutralization can be performed so that clinically significant antibodies may be detected. So you can use some of those different techniques to help enhance those reactions. So here we have another example of one of those cold reactivity antibodies, and you can see that it reacted at immediate spin with 1+ and 2+ reactions. It was incubated, still showed some reactivity, although it did decrease. And then at that AHG phase, then you're still showing some reactivity. So typically when you heat up your tubes, if there's an IgM type of antibody that's present, then it's going to cause that antibody to not agglutinate as good. So it's actually going to get rid of them. But here in this case, the antibody is so strong that you're still seeing it bridge over into that AHG phase. If I were to have a patient that demonstrated this, I would honor whatever it is, that cold reactive antibody, the best I can, although sometimes it's a little hard. This particular case, they said it's a Lewis B. We'll take a look here and see where Lewis B is at. Yes, you can see that your reactivity is taking place with all of those Lewis B. We could go through and do this rule-out process, but that's just going to make this PowerPoint longer. Autoantibodies usually react with all reagents and self and donor red blood cells regardless of the antigens present. And this is when you have that autocontrol and the DAT that are positive. So it is important to identify if you have any underlying alloantibodies when you have an autoantibody present. If it's present to the point that it's interfering with all of your testing, then that means you may need to do some various techniques that will help remove those autoantibodies. And one of those techniques is absorption. I believe we have another slide to kind of further explain that. Cold autoantibodies, typical cold autoantibodies will react at immediate spin, especially when you're doing your cross match, and you will have a positive autocontrol as well as a DAT. And that DAT, if you were to do the poly and then break that down into the IgG and C3, then you will see some C3 reactivity. Cold autoantibodies can happen in individuals who have a history of anemia as well as mycoplasma pneumoniae or infectious mononucleosis. So you get some of those abnormal proteins in there that cause those cells to agglutinate. Most of your cold autoantibodies are anti-I, anti-H, and anti-IH. You could run a cold panel that would aid in identifying those. So an example of a cold panel here where you've got that reactivity at immediate spin, and of course you see it weakening. This particular one, I'm not really sure, they didn't say here what the actual antibody was, but you can see reactivity. You could see that there was reactivity in every one of those cells. Now, to avoid cold autoantibody reactions, you should use a monospecific IgG reagent when you're doing your AHG testing rather than a polyspecific. So when you've got polyspecific, you've got that C3 in there, which again, that C3 could potentially react. You're going to skip your immediate spin cross match and your 37-degree spin. So basically what you're going to do is go through the incubation and everything, but instead of actually reading those reactions, you're going to use the albumin to enhance it. So when you're putting it in the incubator, and you're going to pre-warm everything, so you're going to pre-incubate your tube with your reagents and things like that, And then you're just going to go straight into that wash phase and your AHG phase in order to detect any reactivity. Now, the textbook notes that washing with warm saline is not advised when you're pre-warming the tubes. When I've done pre-warmed cross matches, if it is a really severe cold autoantibody, and I'm talking about one of those that it is affecting the results throughout the entire lab. So over in hematology, they're actually having to stick the patient, put a heel warmer on that tube, literally run it to the lab, and the machine is primed, ready to go, and you are literally inverting that tube as you're running to the lab, and you're doing a manual testing on that machine to test that blood and run it through the machine, because as soon as the cold hits it, it starts agglutinating. So severe cases like that, I've had to use pre-warmed saline as well to do that manual wash step in order to help to alleviate that cold autoantibody type of reaction. You could also use some absorption techniques if you've gone through and used, all of your techniques to try to find a compatible product for that patient. So the pre-warming, again, you're going to kind of go through those steps where you're going to pre-warm all of your containers. So your tubes will set in the incubator. Typically, you're going to go ahead and put your reagent cells and things already in that. Your reagents will be in the tube. So you kind of got to deviate from usual normal procedures. And maybe you're going to incubate your cell suspension and your serum, so you might incubate those for a few minutes, and then you're going to add those tubes while they're actually sitting in that incubator. Again, everything's pre-warmed, and then while it's sitting in that incubator, you're usually going to let it incubate 5-10 minutes, whatever your procedure says. So that's kind of like the pre-warm period. And then from there, you're going to, like I said, everything's going to be in the incubator ready to go, even down to your pipette. Your pipette will be sitting in your samples. So you don't want anything to come in that's cooler to try to enhance those reactions. And you're basically going to pipette while everything is still in your incubator. And you're going to kind of like shuffle it around and while it's still down in that incubator, and then you're going to let it sit for 30 to 60 minutes without removing those tubes. You're going to fill it up with that pre-warmed saline. You're going to centrifuge it, do that wash each time with that pre-warmed saline, and then you're going to add that anti-IgG and centrifuge it and read your reactions. Hopefully you've done enough of that pre-warm process to alleviate any of that reactivity and you actually get negative reactions. But it's pretty much a very tedious process. Most techs don't like to do it. I never minded, but I'm kind of weird. So I mentioned a lot of this troubleshooting that you could do of different absorption techniques to help with that antibody identification. Now, depending on the lab that you're working at, most of your hospital labs don't really fool with these absorption techniques. Like I said, you're going to encounter it only a few times throughout the year, so trying to keep up with the competency of doing it and all the regulations that are required with it, most labs aren't going to do it, so those again are going to be things that go to the reference lab. But just so you kind of understand the process, you could use the rest solution, which is going to actually remove those IgM antibodies, particularly the anti-M. But what it can also do is absorb the anti-B and other IgM antibodies. Some of the other things that can be done for those absorptions, like auto absorptions, if you are suspecting a cold, then what you will do is actually take the patient's red cells, because again, if it's an auto antibody, it's an antibody against oneself, and it does require extra blood to actually do this process. But what they will actually do is take the patient's red cells, let it incubate with the patient's on serum or plasma or whatnot, and you're going to allow time for those auto antibodies to absorb onto those red blood cells. And again, the warm auto absorption is the same process. So it goes through a process where you're allowing the patient's red cells to remove those antibodies, and then you'll spin it down, remove that plasma, and then you repeat this process again with more of the patient's red blood cells using that same aliquota plasma to hopefully remove all of those antibodies, and you would do different enhancement and things to assist with that along the way. And then you also have differential absorption. So this is when maybe you've got a patient that has been recently transfused or something like that, and you're trying to remove particular antibodies is to let some of these other ones show through, or a patient's got multiple antibodies. So this is when you'll use cells that are phenotyped for a specific match, your warm autoantibodies versus your allo antibodies. So it's basically looking for that specificity for that particular allo antibody that you're looking for. Again, it's a very complicated process and procedure. Not likely you're going to encounter it. Just know that these absorptions are what these larger reference labs are going to do to work up some of these more complex cases. Now, your warm autoantibodies are more common than your cold autoantibodies. And what happens with these is you get a warm autoimmune hemolytic anemia that can be idiopathic, or it can be a result of a disease or a drug. And so it's going to cause these warm autoantibodies. So in other words, the patient's got in this process of attacking their own cells. And so when you see this, most of your panel cells will be positive, including the autocontrol. Some of the things that can be done to help reduce this reactivity is to use your 22% albumin to kind of help decrease that reactivity. And then also making sure that you have no underlying allo antibodies. So you might have to do some auto absorptions and some other testing to kind of help with this process. Again, not likely something you're going to do in the hospital laboratory. I won't say never. It just depends on where you're at and how big that blood bank is. But typically it's just going to be, this is more reserved for your reference labs. Specificity. So most of your warm autoantibodies are directed to the Rh system, especially the little e. The patient will have an anti-little e antibody and the e antigen. So in other words, they've got the e antigen, the little e antigen, but then they've also managed to develop an anti-little e. You will see this, like I said, a lot in the Rh family. I think I've even seen it with kale once, but I know I've seen several within the Rh system where they are actually antigen positive, not been transfused anytime in the past several months, sometimes a couple years, and then you're seeing that anti-E. Now with these patients, you're going to see a positive DAT, and of course, if they've got that antibody, even though they have the antigen themselves, you're going to have an increased survival of those red blood cells if you give them negative for that particular antigen. Now, medications can cause formation of warm autoantibodies as well. So there are some drug mechanisms involved. And your textbook does list some of those that can cause some problems here. You may see it. A lot of times you're not even going to know that this is what the cause is. Usually you're going to end up sending this to the reference lab. They're going to do some testing. They're going to ask you to send the list of the patient medication. So usually you're going to have to get the nurse to assist you with this, to send you that list of medications, and then you will send it with that sample to the reference lab so that will aid them in doing that workup to see if it's the drug that's possibly causing the issues. Elutions, now these are fun as well. So with an elution, this is going to be when a patient has a positive DAT and you're trying to figure out, okay, what's coating those red cells and causing that DAT to be positive. So remember that DAT is looking for coating in the patient's body. So we're looking to see if they have been coated in vivo within the veins. But we're going to do our testing in vitro. So we're going to do that testing in the tube. So what this is looking for is the recovered antibody will actually be eluted off of those red cells, and when we elute that off, that is called an eluate. So that eluate, once we've gone through the process to try to remove those attached antibodies on those red cells, we're going to kind of break them off of there. There's a couple of different things that we can do that. You're going to break them off so that they're free floating in that eluate, and then from there you're going to run that antibody test. So one of the things that you will do very often that's an elution process will be to check for hemolytic disease of the fetal newborn when you're looking to see what antibodies have actually coated those fetal cells. So again, I said there's a few techniques that you can do. You can do a glycine acid that's going to lower the pH, which is going to cause those antibodies to be removed, and this is a commercial reagent. There's also a commercial reagent of an ether methanol chloride chloroform that will also help with removing those. And then the one that is really very easy to do is the heat freeze thaw type of method. So this is an actual physical method. So basically what you do is you take those red cells in a little bit of saline, and you'll take those red cells after you've washed them. We do this mostly with our looking for hemolytic disease of the newborn, where we're looking to see if those baby's red cells have been coated with mom's anti-A or anti-B. And so what we do is actually freeze those red cells for a little bit of time, in 10-15 minutes, whatever we can do to get a rapid freeze. And then what you'll do after that is you'll actually run them under warm water to do a rapid thaw. And when you do that, it actually ruptures those red cells and it releases those blood type antibodies. And then we can do some testing to see if that is what's present. All right, our absorption techniques. So again, this is with your warm autoantibodies, where you may need to remove those in order to look for any sort of alloantibodies. So the cells can be pre-treated with various reagents to actually remove any of those in vivo attached antibodies. And then it goes through these various steps where you'll take the patient's serum, and then you'll treat the red blood cells to try to remove any of those autoantibodies. And then you will return the patient's serum to those treated red cells, and you'll incubate it for an extended period of time. And what you're doing is allowing those antibodies, if they're present, to attach to those red cells, so that when you remove that serum, then you're just leaving, hopefully removing everything but those autoantibodies, because hopefully they're attached to the red cells by now. And then with your allergenic absorption, so in a separate tube, you're going to incubate the patient's serum with the different phenotypes. So depending on what you're looking for, so this particular one, they're looking for a particular makeup of these cells. So this is what they incubated it with, so that hopefully whatever you're looking for or whatever you're trying to remove, let's just say if you're trying to remove kale, it's going to attach here. So hopefully it's going to be removed from that particular tube when you do that testing. And then you're going to remove that serum, and then you're going to test that serum separately. So these allergenic type of absorptions, you're going to know what antigens are present on those cells, so that you know what you're potentially removing, what particular antibody you're potentially removing. Some of the other problems that we see in blood bank, phenotyping the red blood cells that are coated with IgG can be a challenge. When you have, so like if you've got a DAT positive red blood cell, let's just say you're testing a patient, their DAT is positive, and you're trying to phenotype them. Well, if the particular phenotype reagent actually goes through an AHG phase, then obviously you're going to get a positive reaction because of that DAT being positive. Treating cells with chloroquine diphosphate will actually disassociate the IgG form disassociate the IgG from the red blood cells without actually harming the antigens. All right, I think that's it. And of course, our reference is our textbook. And thank you for listening to this long, very long lecture.